What we are going to talk about in this webinar is we're going to talk about what happens when we get negative blood results when we're suspicious of rheumatology disorders. So let's set the scene a little bit. We are not talking about when we're in a rheumatology department. We are talking about when we're in somewhere like primary care or wherever you might be organising bloods from outside of rheumatology, either community rheumatology or secondary care rheumatology. So that's what we're talking about. We're also not going to go over why you might have requested the bloods. That's entirely separate subject, and it takes me roughly a day to teach on that. And so we're not covering that. So the scenarios that we're going to go through are going to be that we have ordered bloods, or somebody has ordered bloods for something we suspect might be rheumatological, and they have come back negative. So we are going to try and practically talk through what we might do with some decision making. Okay, so that is the idea of the next 20 minutes or so. We are going to have a quick overview of what some of the rheumatology bloods are, just so we're all on the same page. Then I've got three sort of scenarios for you, I suppose, where the rheumatology bloods have come back negative: swollen joints, inflammatory back pain, and widespread pain. So hopefully those will zero in on some of the practical element for pardon me, for us, and that will get us going where we need to be. So the rheumatology bloods, first of all, so we're not going to spend too much time on this. The first things that we're probably going to see a lot of is inflammatory markers. These are very non-specific, but they are in some diseases fairly sensitive. So what we're going to see, obviously, in an inflammatory condition is we would like to think that the inflammatory markers are going to be elevated. So they're going to show an escalation of inflammatory process in the body. The two main ones that we're going to see are erythrocyte sedimentation rate, or how quickly your red blood cells sink to the bottom of a test tube. So the faster they sink, the higher the rate. And C-reactive protein, and this is a protein that is in the bloodstream in relation to acute inflammation. So ESR, erythrocyte sedimentation rate, is the marker of chronic inflammation. CRP, more of a marker of acute inflammation. So these are obviously really useful to say whether there is more than usual inflammation going on within the body. If there is debate over whether we should order both of these or just ESR, it would be very unusual for the ESR to be raised and the CRP to be not. But it can happen occasionally. The other issue with these inflammatory markers are, of course, they don't tell you the source of the inflammation. So lots of things are inflammatory: being unwell, having an acute injury, having inflammatory disease. What else? Lack of sleep, stubbing your toe, being stressed, being overweight, other metabolic disorders. These all can raise your inflammatory markers. So these show us whether there is inflammation in the body and whether it's more than normal, but it doesn't tell us the cause at all. Typically what I would suggest for people is we're looking around, if you want to be dead certain, really confident, we're somewhere around 50, an elevation up above 50 is commonly cited, but technically anything that is elevated. The other problem with this is they do not always show elevation in the rheumatological disorders. So there are false negatives and there are false positives. Moving swiftly on, we have autoantibodies. Now, these tend to be much more sensitive and can have some specificity to them as well with the rheumatology disorders. So the first one is probably the most well-known, and that's anti-CCP. Don't ask me to pronounce the CCP, citrusylinated protein. I can never get it. But anyway, anti-CCP antibodies. These are autoantibodies. They are antibodies created against the self. So antibodies target specific things. You have antibodies to the influenza virus, so on and so forth. Dare I say COVID-19. And these ones specifically directed against the self. Typically in rheumatoid arthritis, this is against the synovium and the tenosynovium. So if you have positive anti-CCP antibodies, you have rheumatoid arthritis. About 95% of our rheumatoid arthritis patients are going to be positive for anti-CCP. We also have slightly less specific ones, and these include anti-nuclear antibodies, or ANA. You'll have heard of that. There's controversy over what we do with positive ANA results, and also rheumatoid factor as well. Now, anti-CCP, highly sensitive, highly specific, 95%, but that still means 5% of our rheumatoid arthritis patients are going to be negative for anti-CCP, so 1 in 20. ANA, it has a very high, or has a high positivity rate in the normal population, and also technically positive would be of a titer of about 1 in 40, and we want to be looking at higher than that, but it depends which disease you're looking at as to how much notice you take of different elevations of ANA. So that gets quite complicated, and also rheumatoid factor, that is commonly elevated in the asymptomatic population as well. So again, we are taking into account false positives and false negatives. The other problem with anti-CCP is it's not always available in primary care. It does seem to be increasing in its availability, but it isn't always. So we do need to be careful with that. Now, the biggest problem in my opinion with the autoantibodies, especially something like anti-CCP, is if it's not rheumatoid arthritis, it's obviously going to be negative, so you need to be dead confident that you have the right differential diagnosis. But anyway, that's a bit for later. So those are autoantibodies. Then we have, I've lumped them together, or others. So HLA-B27 is your genetic test, and HLA-B27 associated disorders, you're either positive or you're negative. There's no number involved in that. Those related disorders, things like Crohn's disease, ulcerative colitis, acute anterior uveitis, and psoriasis, but also types of arthritis such as axial spondyloarthritis, psoriatic arthritis, the spondyloarthritis umbrella conditions. So again, this has a normal value in the population of a genetic positivity up to around 8% in the Caucasian population, some places higher as well, up as high as 12%. And in the, let's take axial spondyloarthritis, for example, you're about 90% positive in the male population with axial SPA and about 85% in the female population with axial SPA. So again, reasonable use, but you've still got those negatives, and only about 1% of people are going to go on to get a spondyloarthritis, and of course 8% are HLA-B27 positive. So again, you have some false positives and some false negatives there. Now, other rheumatological interesting bloods that can occur in inflammatory disorders, we commonly will see a low vitamin B12 count, which again, not uncommon in the population. It's a marker of it can be marked of chronic inflammation, can lower your vitamin B12 value. Also, white cell count typically is elevated because you've got more of an inflammatory process going on. But again, a bit like the inflammatory markers, if you're unwell, that's going to happen as well. And we do see some types of anemia as well related to chronic inflammation and chronic diseases. So you might see low B12, low hemoglobin, raised white cell count, but again, they're non-specific, and they're also not always raised in the rheumatological disorders. So you can see we're going to have this population. Hopefully what we're going to achieve in a minute is we're going to see some patients who have these results positive who do not have a rheumatological disease, and we're going to see some patients who have these negative who do have a rheumatological disease. So what do we do when the results are negative? And that is what I hope to give you some ideas on now. So let's talk about our face first. Let's not talk about our face. Let's talk about our first case scenario here, and this is in the case of swollen joints. So we're talking here peripheral joints, typically small joints, hands, wrist, That's commonly where we're going to see the multiple swollen joints, where we're thinking maybe a rheumatological cause. So we're seeing multiple joints. We're not typically seeing single joints here, although in some conditions, gout, for example, osteoarthritis, we might see single joints. But we're talking multiple joints here, so our differential diagnoses are going to be somewhere between rheumatoid arthritis, maybe lupus, maybe psoriatic arthritis, something similar to that. So typically, we're going to see with swollen peripheral joints, someone's going to get an ESR, a CRP, an anti-CCP, and a rheumatoid factor. So what do we do when these are negatives? And there's a few different scenarios that we can apply to this, okay? So let's take a typical rheumatoid arthritic pattern. So patient is attending with MCP joint swelling and morning stiffness, and they have a family history of rheumatoid arthritis, okay? Now, if they have red hot swollen joints, morning stiffness, and they come back with a negative ESR and CRP, negative anti-CCP, and a negative rheumatoid factor, they might be one of those 1 in 20 cases that is negative for everything. So at that point, if your suspicion is still very high that the cause of the problems that the patient is having, I would probably still refer into rheumatology for further investigations if your suspicion is really high, okay? Now, it could be that actually they don't have rheumatoid arthritis, they have a masquerading disease, so something like polymyalgia rheumatica can present like a peripheral rheumatoid arthritis. It might also be that they've got lupus, which is again masquerading as peripheral joint arthritis. So there are those possibilities, and in which case the bloods are more likely to be negative. So that's that case that I was just sort of talking about, where you've taken a swing and a miss at the correct bloods and got the wrong ones, you or whoever's ordered the bloods. So that is one scenario. The other scenario here is where you're suspecting rheumatoid arthritis. They've got some swollen joints, red hot swollen joints. They have no family history of rheumatoid arthritis, and they don't really have symptomatic inflammatory subjective signs, okay? So objectively, red hot swollen joints, but they're not reporting stiffness, they're not reporting the symptoms being worse in the morning, or they're not reporting it being significantly better with anti-inflammatories. So at this point, that will bring your suspicion down, okay? Because they're not reporting those typical inflammatory pattern symptoms. At which point you have two sort of options. You can symptomatically treat it somehow with whatever regime you deem appropriate. So you might physiotherapy or medication, whatever that might be, and that's obviously going to vary case to case. But it also might be that something else is going on that's causing an inflammatory reaction, something like an infection or something similar to that. So we need to be making sure we are reviewing the whole case when these bloods come back negative, and making sure that we're getting the appropriate assessment done. Now, the other thing that you could do in this scenario would be to get imaging. And then what we're going to be looking for is obviously things that we want to find imaging-wise related to the thing that we think is wrong. So in a rheumatological cause, we're going to pretty much look for synovitis and tenosynovitis if we're thinking about swollen joints of the hand. So you're going to be, an MRI is a good option, but an ultrasound, especially if someone in the clinic that you're working at can do that, that's a really useful tool to get really accurate visuals on what is going on, tenosynovitis and synovitis. I tend to, if I'm going to do that, I'll ask for the MCPs and the wrists. The MCPs will be classically involved in the rheumatoid arthritic patients, and the wrist typically classically involved in the connective tissue disorder patients. So that is another way. So when your objective markers or your investigative markers from the bloods come back negative, you can, if you're still very suspicious, target a different investigation, which in this case I would think would be imaging. So that can be really useful, and then that's going to come back obviously with findings or not with findings, and then you can make a decision there. Now, depending on where you fall on this suspicion sort of, I was going to say ladder then, but sort of this, how high up your suspicion is, there's other things that you could do. So let's say you think it might be related to their occupation or their hobby, and they're just aggravating the hands maybe, or whatever it is. then you could go for a trial of some sort of hand therapies, physiotherapy or occupational therapy, whatever is appropriate, and see if they improve. And at which point I would be safety netting them for other types of symptoms that might be related to whatever it is you were suspecting them for. And if things change, to come back. The other thing would be is if they don't improve with therapies, to come back for a review. And I would say 3 to 6 months is not a terrible time to redo the blood tests at that point. You wouldn't necessarily redo something like HLA-B27, but if you could redo ESR CRP, for example, and just see if there's a change at 3 or 6 months, if they're continuing on with symptoms or if they're not improving. So that is another way of doing it alongside the imaging. So what I advocate for, especially in this swollen joint cohort, is when you're going to be investigating, you are targeting a specific differential diagnosis. So you're not just scattergunning everything. You're going, I think they have this, and I'm going to investigate them for that. Because if you do it all, of course, think about what we're doing here with rheumatoid arthritic joints. So our sensitive one, or our specific one, is only the anti-CCP. Everything else is non-specific. So ESR, CRP, ANA, rheumatoid factor, all of those are all non-specific. So they could come back as false positives. So the target is the anti-CCP. If you were thinking it's a spondyloarthritic, you'd be targeting the HLA-B27. So that is how you're going to try and improve in that way. And then the same with the imaging. So you're targeting a specific imaging finding. You're not going, can you image this and see if you can find a cause for the symptoms? It's what am I looking for? I'm looking for synovitis, or I'm looking for tenosynovitis, etc. Okay, so we're going to move on to inflammatory back pain now. So this is a really common one where we've talked a bit about rheumatoid arthritis, and we're going to, 95% anti-CCP. That false negative is, it's low. It's not that high. If you add a family history in, it's just not going to come back negative. So it does make life a lot easier. But the inflammatory back pain, we're going to get a lot more false negatives. So remember what I said, HLA-B27, you're looking at 90% in males and 85% in females. But if it's psoriatic arthritis, then you're probably down around 50%, okay? So there's a really big gap as soon as you start delving into the spondyloarthritis for these false negatives. So typically here, when we're doing inflammatory back pain, we're going to be looking for ESR and CRP, HLA-B27, which we want to be positive, and obviously rheumatoid factor as well I've put in here, but here we're looking for it to be negative, okay? So rheumatoid factor is typically negative in these patients. So actually, if you see a rheumatoid factor positive, it makes it less likely, especially in psoriatic patients. So patients with psoriasis, it's very unusual for them to have a positive rheumatoid factor. So as we mentioned, 90 and 85% for axial symptoms, but if it's psoriatic arthritis, down at 50%. So what happens when these come back negative? So again, you've got a few options. They are similar in a way to the previous options that we talked about. The good thing, I suppose, here is this separation with rheumatoid arthritis is related to the comorbidities. So if you've got a patient who has other inflammatory comorbidities and inflammatory type back pain like Crohn's or colitis, then to be honest, I would disregard the blood results, because if you have, let's say you've got ulcerative colitis and then you develop inflammatory back pain, that's a very high chance of getting spondyloarthritis. So we spoke already about a 1% chance in the population for getting a spondyloarthritis. In the ulcerative colitis, it's about 25%. So huge difference there between the likelihood of developing a spondyloarthritis. So in those cases, NASS, the National Axial Spondyloarthritis Society, did a campaign called Back Pain Plus. So if you've got back pain plus one of those inflammatory conditions, then you're just highly suspicious for spondyloarthritis. If it has an inflammatory flavour to it, off that goes to rheumatology for further investigations. Now, typically, the ones we're going to have a struggle with are those patients who have inflammatory type back pain, negative bloods, and no other comorbidities. So they've got just a pure axial spondyloarthritis, in which case, if those come back negative and you're still suspicious that it's related to inflammation, at that point, I would definitely go for an MRI, stir sequenced, T1 and T2 weighted. So T2 is the stir sequences, MRI, whole spine and sacroiliac joints, and that will give you a really good marker. So then if it comes back with negative bloods and a negative MRI, you can be reasonably reassured that you can go on to send them for a course of physiotherapy or whatever MSK therapies you think appropriate. Again, safety net them in case the symptoms change. Bring them back at probably this time at a year if things don't change, and redo if necessary if there's no improvement. But you can be much more reassured in this population with negative bloods and negative MRI. Obviously, if the MRI comes back positive, that gives you your further information to refer into rheumatology. Now, typically, like I say, I wouldn't be doing an MRI in primary care, but I would do it in those scenarios where the bloods have come back negative and you retain a strong suspicion for an inflammatory cause for the back pain. Caveated with, if they've got inflammatory back pain and that inflammatory comorbidity, psoriasis, for example, ulcerative colitis, I would just disregard the bloods. I wouldn't get the MRI. I would just send into rheumatology off the back of that information. Okay, and our final scenario here is probably the hardest, definitely the hardest. And this is widespread pain. So at this point, we're talking about either fibromyalgia, and we're looking to see if there are any other underlying related conditions we need to be managing, or it's something like a connective tissue disorder. So we don't have anything really specific to target. So there's no inflammatory comorbidity, no inflammatory spinal pain, no specific tendon involvement. So we're not thinking spondyloarthritis, no red hot swollen joints that clearly look inflammatory that we can target for rheumatoid arthritis. So we're looking at this generalized widespread pain, probably with fatigue, almost certainly with fatigue. And then at that point, you don't have those other markers to target. So without a reason to think there's synovitis going on, I don't want people getting anti-CCPs. I think it's a waste of a test. If you haven't got tendon involvement or specific inflammatory spinal pain, HLA-B27 is a bit useless. So here we're going really with the inflammatory markers and the ANA. And what we're going to see here is commonly normal ESR and CRP, and an ANA that's either not raised or is of a low titer, so 1 in 40 is the most likely. At that point, it's difficult. We're probably going to have to hold on to these patients for a period of time, send them again for the MSK therapies or whatever therapies we deem appropriate, try maybe analgesia, whatever it might be dealt with. But not routinely sending them through to rheumatology without a specific reason. If we're seeing ANA being positive at 1 in 80, then there's a few patients where you would refer those into rheumatology if they've got rashes or if they've got dry eyes, dry mouth, for example, and you're thinking it might be Sjogren's syndrome. So if everything's negative, then really you're bringing down your suspicion of the connective tissue disorders. You can, if you are still very suspicious and they have widespread pain, again, you could use an ultrasound to look for synovitis of the wrist. My camera's flipped, here we go. Synovitis of the wrist, that would be typical in lupus and Sjogren's syndrome if they have a peripheral arthritis, but they don't all have that. So this is a really difficult set of patients, and you have to be really careful, and we don't want to be overloading referrals into rheumatology with people with negative blood. So you might hold on to those patients, send them for musculoskeletal therapies, review them again 6 months to a year, whatever you deem appropriate, if you don't have those other reasons to be then referring into rheumatology. So what I would say is the more reasons that you have that are not bloods, other reasons, so inflammatory comorbidities or the inflammatory symptoms. So in this set of patients, we're looking at the rashes for systemic lupus erythematosus. We're looking at the dry eyes, dry mouth for Sjogren's syndrome, or if you don't have specific arthritis. If you've then also got negative bloods, then there's just no overt reason to be referring into rheumatology. But if you do have those, then you're less reliant on the bloods. So you can still make that referral then if you've got that other further information. Okay, just very quickly before we run on to the questions, you can get lots more from me. Like I said, this will go up on my YouTube channel. You can go there, subscribe to the YouTube channel. Ideally, for me, obviously, do that. But this is the 6th of these webinars that I've done for this year, and I'm planning 2024's set of webinars. But there are also, if you're on my website, rheumatology.physio, I've got courses, books, you name it. I've done loads of things. They're all available on there. So if you have a check out of that, I would be very grateful. So I think I've just got my giant question slide here, so that I can do that, and it matches my t-shirt quite nicely, which is enjoyable. So let's open up the Q&A. I've got a couple of questions here in the Q&A, so we'll do that. Any further questions that people have got, then please do put them into the Q&A, and I will endeavour to answer them. I haven't got a name here, sorry, just initials OW. Are there different normal ranges for the blood tests you've mentioned between male and females? The only difference in the ranges would be with ESR. So female people tend to have a slightly higher erythrocyte sedimentation rate. So normal value is usually stated around 20, 18 to 20, but a female patient, it can be slightly higher than that. It's specifically as well as they get older, and if they have a higher BMI as well, then it can get up as high as 26 to be normal, whereas with the males it tends to be slightly lower, but otherwise we're looking at the same blood results there. Deborah's asked, please repeat what type of MRI we're asking for if we suspect axial spondyloarthritis. So Deborah, we're looking for a spondyloarthritis protocol MRI. That is a whole spine and sacroiliac joint scan. And let me get my terminology correct here. We're looking for caudal views. I think that's right. Caudal views of the sacroiliac joints, and we need them to be T1 and T2 weighted images. So the T2 weighted images are the stir sequences, and they're the ones that are really important for the inflammatory changes in the spine, so that we can see those. If you are not seeing a lot of these MRIs, then you will then need a MSK radiologist or a rheumatologist to interpret them for you. They are quite challenging MRIs to interpret. The inflammatory changes have some specific rules on what counts. So sacroiliitis, for example, the amount of sacroiliitis in one sacroiliac joint, it matters how many sequences that's seen on, how many slices that's seen on, and how much of it there is for it to be counted as sacroiliitis. So if you aren't seeing a lot of those, then you will need help with interpreting those. But the T1 and T2 weighted, that's the important bit, and whole spine and sacroiliac joints. Ahmed has asked, did you talk about fibromyalgia syndrome in detail? I didn't in this webinar, but if you go on my YouTube channel, I have done a webinar last month on fibromyalgia diagnosis, where we did talk about it in detail for about 40 minutes. So you can check that out there. James said, bit of a longer question here, so strap in. Slightly off topic, had a patient with multiple joint pains, late 60s, seen room 2005, diagnosed fibromyalgia. Always better when he swims in the morning. MRI Axbar protocol negative, inflammatory bloods normal. Had swelling, sternoclavicular joint, which showed mild synovitis. Would that concern you? Is synovitis common in some OA changes? So James, I don't know if this patient's male or female, because that probably matters a little bit here, but the sternoclavicular joint counts as the axial skeleton. So if you're seeing swelling with synovitis in the sternoclavicular joint, I would be suspicious of a axial spondyloarthritis in that patient. And you've also seen some mild swelling in the MCP, so I would review that diagnosis. You haven't mentioned HLA-B27. I would want to have that, to know that. I would redo the bloods, inflammatory markers, ESR, CRP, HLA-B27 if it's not already been done. And I think probably redo the ACSPAR protocol MRI if the last one was 2005. I would redo that and see what you get from there. But always be suspicious of a synovitis in the sternoclavicular joint. Not really seen it osteoarthritis of that joint, particularly if it is synovitic, then I'm always a bit concerned over that joint. The other thing about the sternoclavicular joint is it's not an uncommon place to get an infective arthritis either. He is male. Okay, yeah, definitely axial spondyloarthritis. I'm concerned about that. We've got a question about the YouTube name. If you just type the Rheumatology Physio into YouTube, then I come up. You'll see my face in a circle. Click on that one and subscribe. Dominix asks, is HLA-B27 a gene and an antigen? Okay. So HLA-B27 is a gene that increases your susceptibility. So it's not an antigen. There's people with HLA-B27 positive, and you'll have to excuse my knowledge around it, but it's means it expresses the likelihood of autoimmunity against your entheses, but also, as we talked about, it does also include uveitis, psoriasis, the inflammatory bowel diseases as well. So it's, as far as I understand it increases your susceptibility there. Okay, lovely. So if you do have any further questions, then please do put them either on my YouTube channel, or you can find me on social media, Twitter, so on, Instagram. I'm on TikTok as well. Just send me a question on there and I'll endeavour to answer it as well. Thank you for joining me this evening. And I hopefully will see you out on further webinars. Do go and find the YouTube channel. Thanks for the compliments on my hair. Hope you have a good rest of the evening. And yeah, thank you very much for spending your time with me, and have a good evening. Bye for now, everybody. Bye.